Thank you, Dr. Yogesh Shah. Going to the management of when we have a posterior capsular rent, how do we go about? If we saw the presentations by Dr. Mohan Rajan, we saw that his old presentations, he used the limbal route to do the anterior vitrectomy, but then he showed in one of his later videos that how you can do 23 gauge vitrectomy through the trocar and cannula inserted through the pars plana region. So as we said, whenever there is a posterior capsular rent, we have two options. Either we can go through the limbal route or we can go through the pars plana route. Now, when we go through the limbal route, as we cut more and more of the vitreous, more and more of the vitreous from the posterior compartment comes anteriorly, and not only does it come anteriorly, but while coming anteriorly, it increases the size of the PC rent. Also, there is a chance that during this procedure, we might be pulling onto the vitreous at the vitreous base, which can lead to a higher incidence of retinal detachment or cystoid macular edema post-operatively. It's more anatomical to enter through the pars plana region that is behind the iris and cut the vitreous which is posteriorly then and there, so that we are disconnecting the vitreous which has already gone anterior from the vitreous which is there just behind the posterior capsule. This reduces the traction and helps effective anatomical result. So when to use which route? Now, if the visualization of the retrocapsular area is clear, that means the cataract is either not very dense or cataract is already removed and then we have noted the posterior capsular rent, then pars plana route has distinct advantages. However, if there is a dense cataract which does not allow visualization of the anatomy behind the dense cataract, in such a case, one should do an initial limbal vitrectomy, and thereafter, once the cataract has been removed, one can go ahead through the pars plana route for the vitrectomy. In the past, we had only option of 20 gauge, but nowadays with the sutureless techniques, we have the 23 gauge, 25 gauge and the 27 gauge options along with the use of the trocar and cannula. I will be describing the 23 gauge trocar cannula system here, which is the safest for an anterior segment surgeon to learn, and as well as that is something which he can have easy access to. What it does require is a presence of a vitrectomy unit, a trocar cannula system. There are usually 3 trocar cannulas which come in one box, a 23 gauge vitrectomy cutter, endo-illuminator, that is the light pipe, and an infusion cannula which provides the infusion through the pars plana region. Most of these units are disposable units and are available from most of the companies. Only thing what you require is a vitrectomy unit which can accept this 23 gauge trocar cannula system. So a cannula is usually a metal or a plastic body, and it is loaded onto a trocar which has a sharp tip. We will show us how we insert the trocar cannula. Essentially, just before inserting the trocar cannula, we displace the conjunctiva inferiorly so that eventual opening in the conjunctiva and the sclera are not aligned with each other. At the end of surgery, when we remove the cannula, the displaced conjunctiva will have its opening much above the sclerotomy opening, so that the risk of endophthalmitis is negligible. Also, whenever we are inserting, if you can see over here that the trocar cannula system is inserted at an angle. They say that usually about 15 to 20 degree angulation with the surface, and we don't point it towards the cornea, we keep it tangential to the cornea or tangential to the limbus and enter at an inclination. So the initial entry is at an inclined till the tip of the cannula enters the sclera, and thereafter we can straighten the entry. But nowadays the newer trocar cannula systems, you can continuously enter at a 20 degree angle directly till the tip enters inside. Let's see this case when we saw this case, it was a plate haptic intraocular lens, and the intraocular lens was tilting according to the primary surgeon. So this is a decentered plate haptic IOL which we are seeing. It actually, one of the haptics was behind the posterior capsule. So we just did an anterior levitation and we brought the haptics anterior, and at this stage, if you can see, there is a clear-cut posterior capsular rent which is noted. So at this point, we now know we are dealing with a posterior capsular rent. We are seeing that the haptic is brought in front of the posterior capsule and it is inserted into the bag. Now, because it is inserted into the bag, it is safe to continue with this same IOL. But if it would have to be brought into the sulcus, then we would have to explant this and replace it with a 3-piece. We can see the posterior capsular rent, which is very clearly seen over here. At this point now, we know that there is vitreous which is in the anterior chamber, which is connected around the IOL to the vitreous which is there in the posterior compartment of the eye. So initially what we did is we stained the anterior vitreous with diluted triamcinolone, and we removed this vitreous which is in front of the IOL. For this we used the anterior route for the vitrectomy. One thing to remember is always dilute your triamcinolone. There have been times initially when we learnt about use of triamcinolone, we used to inject it undiluted. It used to become a dark blob of white color. We cannot see what structures are behind it, and even if some amount is left behind, and if the patient is a steroid responder, then post-operatively they have a huge IOP spike. So I usually dilute triamcinolone 1:5 before injecting it into the eye. Now, as I said, we will be using anterior limbal route here to dissociate or remove whatever vitreous is present just in front of the IOL. We use the same 23 gauge cutter through the side port. We usually use a vacuum of 200 to 300 millimeters of mercury and a cutting rate of minimum 800. The higher the better. Going a safe cutting rate would be from 3000 to 5000 cuts. Now, this was a cataract surgery which was done under topical anesthesia. We continued with the pars plana vitrectomy also under topical anesthesia. We just used a cotton tip applicator dipped in paracaine, and with that we were easily able to make an incision. I think one of the earlier speakers also mentioned that, remember that the, okay, so we go ahead 3 millimeters from the limbus, and one of the earlier doctors mentioned that use a sharp trocar cannula. What we additionally do is we use a 23 gauge MVR so that you don't have to push the trocar cannula through the eyeball. Otherwise, many a times the main wound which is open might leak. So here we use a 23 gauge MVR, and after we have made the incision with a sharp MVR, then we use the trocar cannula system. So you will see that it doesn't require much of a push. We are actually rotating the trocar so that it goes inside. The trocar is removed and the cannula is left in place. We usually insert 3 cannulas, one in the inferotemporal through which we put in the infusion. So this is infusion sleeve through which the balanced salt solution enters inside the eye, again through the pars plana, and we make 2 more sclerotomies, one on the temporal side and one on the nasal side. Earlier it used to be said that both the incisions should be about 120° apart, but nowadays with the trocar cannula system you can make it almost exactly at 3 o'clock and 9 o'clock position, so that you have access to superior and inferior quadrant as well. So the same steps are repeated, MVR followed by a trocar cannula insertion at an angulation. Now, with the infusion going on, we can understand that the infusion is behind the lens. the vitreous which we are removing is also from behind the lens. So there is no chance of the vitreous which is entangled in the IOL and in the PC rent to come anterior. Everything is happening posterior to the IOL. So there is no risk of enlargement of this rhexis. And at the same time, we are safely removing the vitreous so that the risk of retinal detachment as well as cystoid macular edema does not remain. Again, we can stain with dilute triamcinolone, recheck that the anterior vitreous is clear, especially check that the edges of the PC rent which are there are free from the vitreous tags. So, this is the same patient seen on 3rd day post-operative, and you can see that the cornea is extremely clear, the eye is quiet. So if we are not trying to tamper with the anatomy and we do a physiological intervention and remove the vitreous from the pars plana region, we can see that we can achieve not only good anatomical but also good visual outcome in some patients. So the advantages of this is that it is a segmental approach. It prevents further vitreous from coming into the anterior segment of the eye. It prevents extension of the PC rent and ensures complete dissociation of the vitreous from the anterior segment and does not leave any vitreous tags which get entangled into the wound or the side port. Now suppose along with PC rent if there is also nucleus drop, what to do when your supporting retina surgeon is not around? First and foremost, never try to fish out cataract from behind the posterior capsule. That cataract which has gone posterior to the posterior capsule, don't be tempted to go and fish it out through the limbal route. Rare occasion, I think Dr. Mohan Rajan showed a video where he was doing vitrectomy and that thing came anterior. That's a different aspect. But otherwise, you never go and hold the cataract or the nucleus and try to remove it from the limbal route, because while doing so, you will always be pulling onto the vitreous and with a high risk of retinal detachment occurring. In such a case, do an anterior vitrectomy, limbal route or pars plana route, whatever is convenient to you, so that the anterior segment, anterior chamber is free of vitreous. And in doing this vitrectomy, if you see that the nucleus is dropping down towards the optic nerve, let it go. Actually, as a retina surgeon, I prefer that when I have to remove a dislocated nucleus, it's better for me if it is there right there on the optic nerve rather than if it is just behind the posterior capsule. So when we do start such surgeries, we often take the nucleus and drop it down, complete the vitrectomy and then remove that nucleus. So don't be scared of the nucleus going down. And if a intraocular lens you can implant either in the sulcus, or if there is enough posterior capsule for you to implant it in the bag, and if it is not a very dense cataract, please go ahead and safely introduce the intraocular lens at that time, ensuring that you are not pulling onto the vitreous, because a retina surgeon can handle removal of the nucleus except if it is very dense brunescent through a phlegmatome, through a sclerotomy, and we usually do not use the anterior route. Now, what does the retina surgeon do once he gets such a nucleus drop? We usually go with a combined 23 and 20 gauge vitrectomy. What do I mean by combined? So out of the 3 sclerotomies, the 2 sclerotomies, that is for the infusion and for the left hand for a right-handed surgeon, is 23 gauge, but the right hand incision is a 20 gauge, because up till now phlegmatome is usually only available in 20 gauge. DORC is the only company which gives a 23 gauge phlegmatome, but again we are very wary about how convenient it is to remove a dislocated nucleus with a 23 gauge phlegmatome. So one of our ports is 20 gauge, the rest we maintain at 23 gauge. All these are through the pars plana, and we using a phlegmatome, just like you all do the phaco, we do the emulsification of the nucleus in the mid-vitreous cavity and we can remove the nucleus. In rare case of a dense brunescent cataract, where we feel that the amount of energy to be used would be immense, which would actually harm the sclerotomy, as you all were talking about corneal limbal burn, we can have a scleral tunnel burn as well. So in order to prevent that, we can do an anterior removal of the nucleus, in which case IOL not being there is an advantage, or we can use the flotation of the nucleus on the perfluorocarbon liquid PFCl and remove it through the anterior route. So I'll just show you a video in which a vitrectomy has been done. We are using the fragmentome to impel the nucleus into it, but since this is a very dense brunescent cataract, we decided to anterior levitate it and remove this from the anterior route. So here just we are doing the opposite of the IOL insertion. We are pushing the lens from inside out, bringing it into the anterior chamber, and then it is removed out through the scleral tunnel. This is how we would rarely manage a nucleus which is very dense and brunescent, and this is the only case where an IOL insertion at the initial time of PCR is not indicated. Otherwise, in most of the cases, you all can safely go ahead and insert a intraocular lens. Thank you very much.